had been achieved. Now, dealing with the hotspots and the other districts across the country, they have an eye on areas where, if it becomes necessary that there's a lockdown, they would impose a lockdown and curfew in those particular hotspots or districts, as you may call it. Therefore, the narrative or the view by some that we have lowered our response is incorrect. As we have gone through and tried to demonstrate, you notice that many of the instances we've either maintained it or we have enhanced it. And even in the case of the last one, the lockdown, which was just Greater Accra and Greater Kumasi, and not even across the country, that amendment has been explained of the new measures that are put in place. The role of the security agencies, we are told in the coming days, is going to change from enforcing a lockdown to helping us comply with all of the other measures that we are going through. So just a quick reiteration of the government response program. Government has not lowered the program. Indeed, as we have gone through in some of the instances, we actually enhanced those, and we'll provide some more details later. Now, one of our strongest tools is our testing capacity and our testing capability. We want to invite Professor William Ampofo, who is the head of virology at Noguchi. And they are also leading the entire testing program, which is coordinating a number of labs assisting Noguchi in this testing exercise to help us legitimate questions that have come up about our testing. We can rely on that data. Professor Ampofo, please join us with that. Just a moment for them to sanitize the podium.
Good morning, ladies and gentlemen. Thank you, Honorable Minister, for this opportunity to discuss our testing program. First, I would like to thank my colleagues at Noguchi, at the Kumasi Center, KCCR, Services Directorate Lab, and the CSR Lab, all together working day and night. I think there are close to over 150 people who have worked tirelessly to described on Sunday. Now, if you've been to Noguchi recently, you'd have seen the white building, the entrance of our institute. This building actually facilitated the process. It has enabled us to test thousands of samples within the recent couple of weeks. How have we done this testing? As you have heard, you cannot see a virus. So to test for the virus, we actually extract the inner component of the virus, and it's called ribonucleic acid. Now, how do we collect the sample, or what kind of sample do we use for the testing? Because this is a respiratory virus, we look for the virus in the respiratory pathway, okay? So we take swabs from the nose, swabs from the throat. We also take sputum, which you bring out from the throat. And then we also have another method where we introduce salt water into your nose and you blow it out, and it's called nasal lavage. So these are the 4 types of specimens or samples we have used in Ghana to test for the coronavirus. When these samples arrive at the lab, whether it is Kumasi or Noguchi or the VSD or the Public Health Reference Lab, we go through a process to enable us to utilize the reagents or chemicals in a very efficient manner. We simply pool the samples. What is pooling? Pooling just means that if you have 1,000 samples, you put them in pools of 10, and therefore you test at a time 100 pools. So in a short time, instead of testing only 1,000 samples, you actually test 10,000 samples. This simple arithmetic is what some people cannot do. If you want to understand how we are able to utilize our existing facilities using a method which was derived in 1945 for screening samples right from the blood bank, this is a very efficient way of proceeding. The other thing we've done is that to ensure that we are actually not diluting the sample when we mix 10 of them together, we simply took one positive sample, which was at the limit of the detection of our system, and diluted 9 other samples which were negative. Therefore, we would determine that if we pool 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 together, we are still able to detect the first sample, which is at the limit of the positive detection. Again, with our partners, we have the late kind of equipment to be able to do this direct detection. So, when we started, we realized that as the number grew, we were actually pooling 5 samples, and then we changed to a pooling of 10 samples. And this simple protocol was followed both by colleagues in KCCR, and of course, it's now adopted by our colleagues here at PHR BSD. So in a nutshell, you can understand that it is not impossible to have tested 68,000 samples, as His Excellency the President reported when he addressed all of us. Actually, since he addressed us, we have actually tested close to 30,000 samples, again, using the same method, because each time we do 10,000 samples is actually, a multiplication of a simple initial number. So please do not be surprised if in the next couple of days you hear that we have tested 100,000 samples in Ghana. It's just a matter of, multiplication and addition. Now, how efficient is this process? We don't just test. Each test that is done follows quality control step as indicated by the manufacturer. We have actually used 4 different PCR kits in Ghana. 2 of them provided by the World Health Organization and the Africa Centers for Disease Control, and also the West African Health Organization. So you can understand that the test kits that we used are according to international standards and verified by these organizations to ensure that the process we are doing is in line with the applicable procedures. Also, we have established a common quality assurance program where we have exchanged samples between KCCR and Noguchi to ensure that samples that we say are positive at Noguchi are also checked by KCCR. And we have also done the same thing for samples from KCCR. Furthermore, the WHO has established an external quality assurance program, and we will be taking part in the external quality assurance program. I understand that the Africa CDC also starting such a program for us in Ghana. You've also heard about rapid diagnostic tests. And the policy that the FDA, the Food and Drug Authority, has adopted is that all such rapid diagnostic test kits have to be evaluated and assessed for their ability to pick up a true positive, which we call sensitivity, and the ability to rule out a true negative, which is called specificity. So this process is currently ongoing, and we have established a panel of blood samples that are truly positive and that are truly negative. We are in the process of reporting back to the FDA which kits therefore are most sensitive and most specific and therefore suitable for use in Ghana. This will then enable us to do more testing, but the results will be in combination with what we call the PCR, so that we can accurately describe as somebody having been exposed, accurately describe somebody as having been infected, and accurately describe somebody as having been previously exposed. It's very important to understand the distinction between these categories, or else people will think that they have the virus, whereas they have just been exposed and they have actually recovered. I think that this is a sufficient explanation of everything that we are doing so far on testing. If there are any specific questions or issues, I think that it brought to attention and we will once again come here. But I must thank all my colleagues in the background who you do not see. They have worked tirelessly day and night in 2 shifts, making sure that we are able to provide the testing to support the COVID response. Thank you very much.
Prof, you're touching my podium. You have to use Tizer. Professor William Ampofo is the head of virology at the Noguchi Memorial Institute for Medical Research. They are coordinating all the tests across the country. Prof will join us later to help us understand a few questions. So we have admitted here on this platform and on several other platforms that out of this about, is it 20,000 currently getting to 100,000 in the medium term tests, there are some tests that have been done more than once. Why? Because, for example, if you look at our recovery rate, 99%, what it means is that those persons were tested 3 times, the first positive test and 2 negatives. At least, if you look at those who were in mandatory quarantine, they were tested at least twice. That is 1,030, and then they were tested about twice. So you will find some tests that have been run more than once. But Ghana is reporting that we have done about 80,000 tests. We have also admitted, nobody has hidden it, that some of these tests have been done more than once. The question is, how many of these 80,000 tests have been done more than once? And does that take away from the view of Ghana's test numbers? If, for example, by the time you do that mathematics for us, it is 0.5% of the tests that are repeat tests. Does that mean that the 99.5% of the tests, singular tests, which showcase Ghana's test per million or Ghana's test capacity, should be thrown away, should be discounted, that therefore numbers are duplicated? Prof, we'll need you to help us later. It fits into the question of whether we are reporting number of tests or people tested. Because the big question is put up, are you reporting number of tests or people tested? But the real question is, what we have admitted about the double test, what percentage of the total test is it? And does that negate the essence of the entire testing exercise? So, Prof, you have to help us to understand all of this. I want to quickly move to case management and case count before I come to this model. Because Dr. Nsiasa, we are all scared. You say 3 million people and 15,000 would die. We are all scared. So we'll come to you to help us with the details. But I want to move to case management. From the Ghana Health Service, Dr. Patrick Kuma Abuaji.
Thank you very much, Honorable Minister. I'm using your slides. Good morning. We'll just give you a brief where we are as of this morning. As you know, we have the cases categorized into general surveillance, travelers, enhanced surveillance, and then the total. Under the general surveillance, as at the 20th of April, which we're reporting, we have 401 cases that are reported positive. We still have the 115 travelers who are quarantined and tested at 115. Through enhanced contact tracing, in the last 3 weeks, we had about 638 positives, bringing the number to 1,154 cases as at today. Out of this, we have had about 120 on having recovered, a change from the 99 in the last reporting. Of these recoveries, 82 have come from the Ghana East. UGMC has reported 17 recoveries. Rage has 3 people have recovered. The 7 military hospitals have recorded 4 recoveries. Terminal Hospital 1, Ashanti region has 6. WA has, in this case, has 1, and Tamale has 6 cases reported. Of those who are well and responding to treatment, including those who are asymptomatic, that comes to about 1,021, accounting for about 88.5% of our cases are well, no symptoms, and those who have mild symptoms are responding to treatment. We have had 4 people currently in critical or moderately severe condition. Only 1 is on ventilator, And these are in Ghana East and UGMC as we speak this morning. So, in a nutshell, this is what we can share with you. A significant number of the people are currently in isolation. Thank you very much.
Dr. Patrick Abadi, thank you for that update. So now we have 120 recoveries. Doc, did I hear you correctly? 120 recoveries? Doc, 120 recoveries. 120 recoveries. Okay, and making our way through gradually. We'll also invite you later to respond to questions that our colleagues may have. Shortly, I'm going to invite Dr. Nsiasare to come and explain this model of 3 million people to be infected, 15,000 to die, to come and explain this model. Before then, it is my understanding that chief executives of state-owned enterprises, the state-owned enterprises themselves, or entities. Is it the entities or the chief executives? The chief executives of the state-owned entities, those that come under SIGA, have also come together with a contribution which they want to make available to the COVID-19 Relief Fund. Honorable Deputy Minister for Information, please join me and let me invite the representatives of the chief executives to join us and to make that presentation. May I quickly mention that the COVID-19 Relief Fund, that money does not come to central government to utilize. I think it's an important clarification we have to make. That money, please come to the front here, please come to the podium, yes. That money does not come to central government to utilize. It goes to the fund which is administered by a board of trustees. A board of trustees led by the former Chief Justice, Madam Sophia Akufu, and they are going to administer that fund in accordance with the law that was passed by Parliament. Social distance observed. So in accordance with the law that was passed by Parliament, the trustees of the COVID-19 Relief Fund are the ones who will apply these funds in accordance with the law that was passed. It does not come from central government. So please let us take note accordingly. There have been those who have donated items in kind that have gone to various ministries and departments that are handling parts of it, like items, etc. And we are grateful to them as well. So, Honorable Pius. Thank you. Very quickly. Mr. Very quickly.
All right. Thank you. We're doing this on behalf of the CEOs and deputy CEOs of all the state entities. And this is an initial contribution. We still have a way to go, and under what we call the COVID support project for the state CEOs and deputies, we will still be making more contributions. And also, this is not coming from the institutions. These are the individual contributions of the CEOs and the deputy CEOs. Thank you very much.
So CEOs and deputies and SIGA for continuing, we are very grateful. Dr. Nsiasare, please join us and explain this model to us.
Thank you very much, Mr. Minister. Yes, yesterday I was at TV and I gave a hypothesis which is a hypothesis that WHO put out, which is based on population of the country. And that's the hypothesis I gave, that if Ghana stayed without doing anything at all, that's what will happen to us as a country. That's the 10% of the population being infected and 20% of them getting sick and about 5% of them getting very seriously ill. But I said, and I'm sure they should have quoted me on that, that is the case in Africa. In fact, based on the data that we have realized that our actual figures are far, far, far below what WHO has quoted. And it's because when we saw the WHO hypothesis, we were a bit scared. So we put a lot of things in place, which the Honorable Minister have mentioned, especially the preventive etiquette, which has become a new normal in the country, social distancing, ban on social gatherings, and also ban on limitation on or restriction on coming into the country, because we realize that most of the problems that we have in this country were imported. So after doing all these things, and also we restricted movement in 2 of our great metropolises to get the data that we are using now. So from seeing the data, it has shown clearly that in Ghana, we won't go in that direction. And luckily, His Excellency the President has added more measures, like wearing masks where everybody here is wearing masks. Because if you wear the mask and you go out, and then your brother and your sister is wearing masks, you don't bring the disease home. As we have always been saying, the virus has no legs. It's human beings who carry the virus. I want to just make it very short that it's not true that Ghana will have 3 million people infected before we reach the peak. We will never see that. Because as we speak now, as Dr. Abuaji said, the number of deaths in the country is 9. 9 deaths. If you calculate it according to the percentage of people who have been infected, it's 0.7%. So it's nowhere near the 5%. If you look at the number of tests that we have done so far, we have 1,154 positivity, which counts about 1.5% positivity people that have been tested. And if you look at even the negative rate, it's about 98.5%. So we are not getting near, or will never get near the WHO hypothesis. But as we speak now, there are a lot of people who are doing modeling. There are different modelings coming out. Worst case scenario, if you do this, if you do that. But the modeling is not even static. It's dynamic, according to the data that we see every time. So at the end, Ghana have a model for this COVID-19. And I can also assure you that when we follow all what the measures that government has put forward, and everybody stay at home when he doesn't have to go out, there will be no much problem. But that's not to say that we are out of the doom. So please, this is what it is, and that is how our affairs are. And as the President said, we'll be back by data and science. Thank you.
Dr. Nsiasia is the President's advisor on health. Just to reiterate the point you have just made, and let me see if I get you correct. Doc, let me see if I'm correct. What you are saying is that this your comment that 3 million people could be infected in Ghana and 15,000 out of that could die is based on the WHO hypothesis or model. But as a second matter, you are saying that even what observing in Ghana, the actuals, does not correspond with that one. And that thirdly, what you are saying is that the kind of measures that we have rolled out, we expect that that kind of global model that they have put in place, which births these numbers, when you feed into it the Ghana population, it will not happen now. Okay, I think I understand you well now. Actually, if you watch the clip of that interview, I think the journalist was also asking you, is it a hypothesis or is this a model? I'm not too sure you caught and answered that part well. And it's part of what has fed into the perception out there. But the clarity you have given us this morning, we are grateful. We'll have an opportunity to have our colleagues ask you some questions later. I think these are the major briefs we have for you today. We're going to take questions at this point in time. Before we do that, it is my understanding that the National Health Insurance Fund has a quick contribution that they want to make. Dr. Selby, can you please join us? Colleagues who have questions, please show by hand, 2 at a time, come to the podium. And while we're waiting for you to come, Dr. Selby is going to come. So, Professor Ampofo, I've already given you one question about number of tests and number of persons, and whether that takes away from the narrative about Ghana's testing efficacy. We also had a second question that we have also noticed coming up, that if you look at the line graph, and there are different types of graphs. So look at the data that the Ghana Health Service provides. There's pie chart, there's a bar graph, there's a line graph. There are some who say that if you look at the line graph, it suggests that you are suppressing the data, that you are recording some cases and not reporting. I'll need to add that to your questions and explain that to us. So National Health Insurance, that's a check of how much?
250,000.
Oh wow, 250,000 cedis. And we are very grateful for this contribution from the National Health Insurance Authority. Thank you so much. Thank you so much. Ordinarily, you should be paying for our medical bills, but since you are not paying, it means you are supporting payment of. Thank you. So we have questions.
Good morning. My name is Pedro.
Go ahead, Pedro.
So question number 1 to the Director General of Dr. CSR. What does the possibility rate on the Ghana Health Insurance Ghana Services website actually mean? Is it at the same as the prevalence rate of COVID-19? And then what is the incidence of COVID-19 in Ghana? And then my second question would be, are we reporting the number of tests or the number of people tested?
I think I've asked that one already.
Okay. And then out of the case count as of today, how many of them are part of the 18,000 backlog of samples the President spoke about? And then if someone is tested and asked to self-isolate while the person awaits the results, how do we ensure that that person really isolates him or herself and do not, step out? At all. And my last question,
Ago anyenye ke anyenhi nyefane achomina ashoko hela kweba jele mina achole coronavirus nineke hela ne.
We have nurses that reaching out to us that they still PPEs to work with. So they're asking the questions, where are the PPEs that are being delivered to facilities on a daily basis? Also today, there was a report that at Mamobi Polyclinic, a midwife there told us that they are selling PPEs to their workers because they do not have provision from the government. So my question to the health service, where are the PPE we've been told about that they've been distributed to all these facilities? And also to Dr. Boaje, on Monday you told my colleague Enes Menu on a program on Joy News called News Desk that our curve is flattening.
Which of the curves, by the way? Hospitalization, recovery, positivity, or
positivity.
What? He said the positivity curve was flattening.
The question was put to him, at this rate, do we have our curve flattening? Then Dr. Baji mentioned yes.
Oh, is that so?
And now that we have 1,154 cases and expected that some more results of a test are going to come, do we still say that our curve is flattening?
Fantastic question. Doc, while you're answering that question, it's important to explain what they mean when they say the curve is flattening. In some jurisdictions, you see them talking about the hospitalization numbers. Some are talking about deaths. So what are we talking about? Colleagues, we are trying to nuance this because a lot of these things are new to many of us who are even purporting to talk about it. So it's important we have a clear understanding of what the concept means and therefore certain nuance on. So Doc, please take advantage to educate us what we mean when we say the curve is flattening. Is it the hospitalizing curve, death, recovery, new infections, etc., etc.? Just a quick comment before we even proceed. Health workers who have challenges with PPEs, we have asked that you also call 311, give us the feedback so that quickly feed it to those who are monitoring the supervision. The gaps can be closed that way, but I'll let Doc respond to that specific question about the hospitals you mentioned. Yes, sir, TV3?
Yes, my name is Godfrey. I want to find out what is taken into consideration in putting somebody under home management.
In the what?
Home management.
Yes.
Yes, and also how they monitored.
Sorry, I didn't get the first question. What is taken into consideration?
People are too sure whether these people are monitored well and then make sure that they are really adhering to whatever they are supposed to do.
Very well.
So the fear is that they might be in the public to infect us.
Very well.
Thank you.
Very well. So Dr. Baje, what determines the decision to manage some people at home? And then how stringent is the monitoring of those who are being monitored at home? The first set of questions are done. Then let me proceed to some answers. Maybe let me do the policy question very quickly. So Dr. Nsiasai, the policy question, the research institutions moving forward, what is the policy intent? How do we want to ensure that they are made very relevant in our health delivery system? Please come.